Hello everyone and welcome to the webinar. My name is Julie Hashida and I'm the Technical Assistance Coordinator for the National Healthcare for the Homeless Council. I will be the moderator for today's webinar titled Preparing for HRSA Operational Site Visits, a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of National Assistance and Special Populations. This session is being recorded. This is a 1-hour presentation with the last 10 minutes reserved for questions and answers. Please submit your questions in the Q&A chat box below the presentation slide. Please type your questions and technical issues during the presentation at any time. A selected number of questions will be answered at the end of the presentation during the Q&A session. The PowerPoint presentation and the recording of this webinar will be posted on our website at www.nhchc.org within 72 hours. Many Healthcare for the Homeless grantees are expecting their HRSA Operational Site Visit, which is a 2.5-day on-site evaluation that assesses the health center's performance meeting HRSA's 19 health center program requirements, along with a financial and clinical performance review. The Council has received many requests from grantees for assistance in preparing for these visits, and today we are pleased to have with us representatives from 2 Healthcare for the Homeless grantees that have recently and successfully completed their site visit review. They will share how they prepared for their visit, what to expect based on their experiences, and their recommendations for other grantees. I'd like to introduce the speakers for today's webinar. Our first presenter is Jenny Metzler. Jenny has nearly 30 years experience working in community-based organizations dedicated to health, ending homelessness and poverty, and addressing violence against women. In Latin America and New Mexico, she has developed and implemented a range of outreach and services programs and led collaborative initiatives of diverse community groups. She joined Albuquerque Healthcare for the Homeless in 1995, and in her tenure served as Development Director for 10 years and Executive Director since then, with one brief hiatus that only strengthened her conviction about the Healthcare for the Homeless mission. She holds a BA in Spanish Latin American Studies from Beloit College and a Master of Public Health from the University of Michigan. Our second presenter is Nilesh Kalyanaraman. Dr. Kalyanaraman oversees all clinical services at Healthcare for the Homeless Baltimore. Previously, he spent 4 years at Unity Healthcare in Washington, D.C., where he was the Assistant Medical Director for Health Services at the D.C. Jail. Subsequently, he was a AAAS Science and Technology Policy Fellow at the National Institute of Health from 2010 to 2011, where he worked at the National Center for Complementary and Alternative Medicine. Nilesh completed his residency in internal medicine at Emory University, received an MD from State University of New York, Brooklyn School of Medicine, and a BS in chemistry from Yale University. Our third and final speaker is Fran Preuss. At Healthcare for the Homeless Baltimore, Fran oversees information systems, human resources, billing, finance, and facilities. She has over 25 years in management experience with expertise in financial systems and services. She was a partner at KPMG Consulting and currently serves as an officer on the board of directors for several nonprofit organizations in Baltimore and Washington, D.C. Fran received an MBA and a BS in Business Administration from the University of Maryland Smith School of Business. So without further delay, I'd like to start the presentation and pass the mic to Jenny. Jenny?
Thank you, Julie, and thank you for having all of us to have this opportunity to share our experiences and what we learned from these sometimes daunting site visits when we're preparing to go through them and anticipating them. So I'm Jenny Metzler. I've been with Albuquerque Healthcare for the Homeless for a long time, as my bio said. And I think it's important to understand that Albuquerque Healthcare for the Homeless, as is the Baltimore project, is a standalone project. So just understanding going forward, our lens, we only focused on the special population as an HCH grantee in terms of the requirements that we're all held to as community health centers. I want to talk a little bit about our preparation in general, and then talk a little bit about the 19 requirements and some specific points about that, and then we'll hand it over. I won't address the clinical and financial indicators. Nilesh and Fran will talk more about that. So we had our operational site visit, or known as a shortcut as the OSV, in June of 2014. And we came out of that, I'm happy to say, with one unmet. And I'll explain a little bit more about what that means for those who are unfamiliar. And I'll just assume that people have different levels of knowledge around these visits. I think we came out with one unmet, somewhat surprised, feeling very satisfied because we had worked hard to prepare. And I think we came out as a stronger team. I can say that it was a great vehicle for getting done a lot of the policy, paperwork, systems, and updates that we had to do anyhow. So this just accelerated the process for us. There are two key documents. We have several more listed at the end of the slides for reference, and there's a lot of information out there and technical assistance opportunities for preparing for these site visits. But I would recommend, and from Albuquerque, we used two key documents, and these are the documents that the reviewers and evaluation, the site team, will be looking and working from pretty religiously and literally. So one is the 19th Health Center Program Requirements. There's a link there. Anyone on this call who is a grantee should be familiar with these 19 requirements. And we kind of carried that around in our wallets and our agendas in our back pockets for many months, just being as familiar with that, and then with the policy documents that support that in more depth. But that one couple-page document is really critical. The other is the January 2014 Health Center Program Site Visit Guide. If you don't have that yet, it's on the HRSA website. There's a link there. That really became our framework for about 4 to 6 months of preparation. We came back to that over and over again. I think in terms of how to prepare, these are very broad stroke things that we learned but kept coming back to, and it kept us very steady and it kept us very paced. First thing is to take it seriously. We are a special population HCH grantee, and so we say out here often that we're special but not that special, meaning we need to certainly comply and we need to understand all the requirements, and we also need to let the world know what is different, significant about the population that experiences homelessness and why it is a special population. So I think sometimes feeling like we're different gives us some sort of permission to approach some of these things differently, assuming maybe that they don't apply to us quite as much. And I think maybe that's the case in some points. We'll talk about the asterisks a little bit later. But I think just taking it seriously and approaching it very systematically unpacks this process. And again, preparation. It's all about preparation. That's what we were so prepared that it really was almost a breeze by the time we got there. I might get in trouble with some of the staff that are on this call hearing me say that. As I said, we prepared months ahead. We didn't wait. As soon as we knew it was coming, we had plenty of heads up. We anticipated that it was probably coming. We had a sense of when. So we had our visit in June, and we began preparing probably last fall, in earnest, probably in November. We formed a work team and created a calendar and a work schedule of regular meetings, huddles, when we wanted to have certain things done, how that fit in with our board meetings and our management team meetings, and then we identified a project lead person to move preparation and to move the work of that team where it felt a little too far off. And I think treating this as from a project management perspective also helped us to be better prepared. We learned and we heard from others. We benefited so much from those who had gone before. And we took full advantage of that, and we heard over and over again that so much depends upon who your project officer is and what your relationship with that person is, as well as who is on the site visit team. And we heard over and over again, your project officer will select a team. There'll be 3 people on that team. One will be a governance admin person, another will be a fiscal person, another will be a clinical person. They'll work together. They'll assign a team lead. They'll work with your project officer. You'll have a pre-planning call with them. You'll have an entry. There'll be one point where they meet with your board of directors with no staff, and then you'll have an exit. And you will know pretty much at the exit where you sit with. There should not be any surprises in your final report. You'll know then. It's a conversation. That's kind of the broad structure of how they will go through those 19 requirements in the site visit guide, and you'll work with them to set the rest of that agenda and those details, who's going to be where, when, who from your team, etc. The nature of those relationships is really critical, and so we heard from people from the moment the conversation starts and even before with your project officer, request someone from the consulting group. Management Solutions Consulting Group has a pool of consultants who go out and do these evaluations and site visits. There are people on there that have extensive HCA experience, current, past, to just request that drumbeat. We got people who had experience doing evaluations and reviews of HCH grantees, which is different. It turned out to be okay for us, but that has not always been the case with our peers. So that's a real critical piece of preparation and advocating best you can for a team that is really going to work with you and understand you. Study the key documents, as I said. I named a couple that will guide you, and then they all tie back to policy information notices that are on the HRSA website, the program assistance letters, and other HRSA policy documents like letters or any clarifying memos. A really big thing for us was examining our team's attitude and being really open, being on the same page. And I would say I think we focused on having our meltdowns and getting them out of the way before the visit, which was a really good plan for us because we just blew off some steam, and we were able to be very focused and very open when the team was there, very gracious even when sometimes we were frustrated or felt like we weren't being understood or that we didn't have something in place or that we did have it in place. And we were able to, I think, move through that experience a little more smoothly because we weren't putting energy into some of the frustration of the stress of this kind of visit. And focusing on our board of directors, we have a very focused, very engaged board of directors, and we just focused them on what we knew that they knew to remind them that they knew it. So they were part of that 4 to 6 month process. So as I said, once you're prepared and you have that framework, you just keep a pace and you just crank it out. And so we sat down first with the 19 requirements. We looked at where we were, what we had, prioritized the work to be done to prepare, and we were very honest with our assessment and looking at what we had and not rationalizing, but being kind of brutally prepared to be over-prepared. And that allowed us to really do our task lists to get those on an agenda and to know what we didn't know and where we needed to call on other technical assistance and documents to sort it out. What we learned, for the most part, was that we had most things in place. It was just how we had them organized, how we had them written up, what needed to be updated or approved by the board. It was about how we pulled it together so that we could present it and demonstrate it. So there's a system of the 19 requirements are either met or unmet. It's either 100% met or not. If you are 95% within one of the 19 requirements in the Health Center program, and I'm assuming everyone has seen this document, if you're 95%, doesn't matter. It's a pass-fail sort of system. So what we did in terms of how we prioritized the work, and it worked in our case, was to, first of all, just look at what is just busy work for us. It's a lot of work to update our bylaws. We did have a biannual process for doing that. It was important. Ours probably needed some revision. It was just a matter of just moving through it. There wasn't an issue on principle. There wasn't an interpretive asterisk there about because we were in a healthcare for the homeless projects. We thought those are the things we just need to push through it. We just need to move the volume. So that was a lot of work, but those were kind of low-hanging fruit for us. Have a plan for the ones where you know you're not going to get there. The one we got an unmet one was billing related to Medicare, and we knew that we weren't there. We haven't really had a lot of eligibility in New Mexico for a long time for Medicaid. That has changed. So we're looking at all the third-party billing, and we're really needing to build a system for that we have not historically in 30 years had in place. So that was something we knew we weren't going to meet, but we made sure that we had a well-documented plan about what we were doing, where we were, and where we were going to go with that. So we didn't meet it because we weren't 100%. We might have been 60%, but at least then that gave us a plan for how we will then address that unmet going forward. know your asterisks. You will see this just about every slide. The asterisks are where it is recommended but not required for HCH projects, and that's written right into the Health Center Program requirement document, the 19 requirements. So just know those asterisks, what they mean, how you make your case. And then also, we had, along with the asterisks primarily, so on sliding fee, that requirement, we knew that we were going to go to the mat on that because we slide to 0. We understood the recommendation versus requirement. We had backup on that. We had a plan. We knew the policy out of HRSA pretty well. So we prepared a really good argument for why we were going to go all the way with that one, and that was met. We did not have an unmet on that. We were very prepared. So again, be prepared to be over-prepared. Use technical assistance. We had a technical assistance peer-to-peer visit from 2 of our peers who are also in the site review, the site evaluator consultant pool. They came out for 2 days, and they walked us through a mock review that was also very supportive. We got copious information. Terrified us at some level, could have shut us down, but then again, we just broke it down. About that time, the new site guide had come out, so they were able to also talk us through. There's an October 2012 guide that is much more detailed. They were able to talk us through how to understand that might influence the mentality of the evaluators who had been doing it for a long time, but how the January 2014 guide is really the one they need to stick to. So that was just really, really helpful. The HRSA website has plenty, including sample documents, which we used for some of those low-hanging fruit. Just update the policy, make sure your credentialing looks like it needs to look and has the language, your MOUs, bylaws, those sorts of things, compliance, corporate compliance plans. We used a lot of samples there and on the NAC site and some other places. National Association of Community Health Centers and your state PCA should be helpful. We called on our state PCA quite a bit. And then talking to peers, both other CHCs in your area, because they've done these with your project officer, and they, along with the Primary Care Association, know what's trending and what experiences have been in your community more locally. And then more specifically to the special projects, we reached out to peer projects across the country, and everyone was willing to share their experience. So again, we were successful, I think, on the backs of those who had gone before. Something else that we did was we included our entire organization. So our project team for preparing for the OSV was pretty much our senior management team. But our entire organization, board and staff, volunteers, and many of our consumers knew we were doing this thing. However much they understood of it, they knew it was important. So we had this cheerleading gallery and people who really gave us space to work a lot for those 4 to 6 months with a real focus on preparing for this. And then when we were successful, there was actually cheers going up as people got the word of what the outcome of our review was. And that felt really good because this became something that was slightly intimidating or overwhelming, became an opportunity and a vehicle for us to really build some team commitment and some focus in the organization. So we're still benefiting from that. So we created a lot of tools, and we did it as much to keep us on track and focused and prepared to respond during the 3 days they were here, as well as to make things easy for the site visit team. So we created a lot of lists and checklists and updates. We did crosswalks, for example, on where we were with our approved scope and where we needed to go, because we came right in the middle of the scope alignment process. And so we wanted to show to them, this is where we are in terms of our approved scope, and this is where we need to go with it through that opportunity. So crosswalks were good in explaining our plans. We created guides for them that showed what community tables we were at and who represented us and how that fit with our strategic plan. So any summary kinds of documents. We had hard copy binders for review in the room that they were working from, and then we also, for our internal team, we all had the exact same binder with key documents, policy backup, briefing memos on what our rationale was going to be on certain things. And it actually was very interesting. At one point, a consultant got here late because his flight was delayed. We'd already done our entry, and someone called and said, get your finance director over here right away to meet with him. And she walked over and didn't have her binder, and she was able to pick one up that another senior manager had left on the table, and she stepped right into it, and she had everything she needed. So the uniformity of the information we were all dealing with and being on the same page was really critical. You'll have an opportunity to do an entry conference presentation, an overview of your project. We did a PowerPoint on that. People do it different ways, but that really helped us to show who we were and to educate them and the context. We completely staged the workspace that we had them in, so all the binders they went to get were right in front of a window that faced our central courtyard where our consumers and clients are. You can do lots of things like that. And then we took that site visit guide, the January 2014 document, and we added columns to it. So that became our work plan checklist, but then we did a cleaned up version and we annotated for the site evaluation team and the reviewers where the documents were that would reference those certain requirements in the guide, and also who was the contact person of the team they were working with who could answer those questions. Again, we worked with our project officer ahead of time and talked some things through with her so that she was prepared when she came. She stayed with the team the entire time, and so she was able to either advocate or explain and kind of circumvent some things. This is really important. Send the site visit team what they ask for ahead of time. You will get very extensive lists of documents, and it's very overwhelming at first. But if you break it down, again, you have most of it. So we sent that to them. They wanted it electronically, and we did send it to them on time, about a week ahead of time. And we sent everything that they asked for. And they said they often request documents and don't get them by the time they've arrived. And so that right there was a great good faith opening with them that was more important than we would have thought. So it seems like the obvious, but do it. Have folks available the entire time they're on site. We were able to do that and be very responsive. And then just take the opportunity to show your best and teach about who you are and what is unique about healthcare for the homeless. So very briefly, because it's detailed and you should know these, but some of the things that came up both from people who gave us guidance and also indeed when they were here and we were going through our site visit. In terms of the need area and requirements, when they say they want a written document and needs assessment that is current and board approved, they do. And several of our peers have really had to argue what that means. They didn't have it necessarily in a separate, discrete, written form. Many of us put that into our service area competitions, and that's where it's written, but they wanted a discrete, separate document. So we worked on that and had that available. It was fine. In terms of the services, I think I talked a little bit about scope of project and required services and sites, and we went and worked exactly from what was in our electronic handbook and on the EHB. Every step of the way on procedures, policies, documents, plans, we used board minutes and committee minutes to demonstrate that they had been tracking all along, were involved in oversight, and that their approval wasn't a rubber stamp, and they looked back to those things. So again, always pointing to documentation in policies, procedures, signage. When you're talking about after-hours coverage requirement, they'll call and check your phone messages, so make sure they're in whatever languages are appropriate and that they have the information needed to comply with that requirement. MOUs and all of our agreements, contracts, affiliation agreements, and other things were current, had specific information about requirements. In those, they were available electronically. We put them on a thumb drive for them, actually, and they were also available in hard copy binders that were very clear right in the room. Management and finance, I think you'll probably hear more about this from Fran, certainly, but it was important for us to know how we stood among others. So those UDS, our UDS data, they came in, they did their homework with an analysis of our UDS data, and then the roll-up or the comparative analysis, and knowing how we compared in cost to other HCH projects, or how we compared to CHCs in New Mexico, and so being prepared to have that conversation. And this is the area where I think I've heard that HCH projects have maybe some of the greatest challenges, which is not a surprise. So know the policy information notices on these issues, and know the asterisks, again, where we are special. And then if you don't have something in place, demonstrate your plan. And I think many of the changing environmental factors around the ACA and the rollout and the context and getting up to speed are particularly relevant for HCH projects, again, because so many people have not been covered. And so that was a good context for us to show our plans, and it all seemed reasonable to them. They understood that. And then on the governance area, know the governance pen and know the asterisks there, particularly on how people experiencing homelessness are, if not elected board members, giving input in a very systematic way to your programs and policies and plans. So a few things to have, real definitive things. Make sure these were things people said, make sure you have this, and we thought, well, you know, we went back, we did it, we researched what they meant by that, we made sure that what we had was documented, and even though it was ours, that it was maybe formatted slightly differently so that they would look at it and recognize it as something they were requiring as well. And so written, board approved, again with minutes, evidence, or whether management minutes or board minutes, evidence of board involvement and oversight in creating your needs assessment, your strategic plan and your strategic planning process, your QA, QI plan, credentialing policy and process, really big with FTCA right now. One of our site reviewers was also an FTCA reviewer. Your corporate compliance plan, your emergency preparedness plan, having compliant bylaws, and there are a lot of samples out there. Having an up-to-date conflict of interest policy is really, really critical. It's like one piece that was very important. And a succession plan for your executive director or CEO, depending on the title in your organization. All of these things at some point we do, and at some point creating these documents and packaging them felt like we were taking pieces of things and just shifting the order of the table of contents. But it was something that we have been planning to do this year, and now we're however many months ahead of ourselves. So that is just some gist. Call me. I'll share anything, as will many of your peers, and the contact information is there. I hope this has been helpful. Look forward to the questions, and I will pass it on to Nilesh.
Thank you, Jenny. So Jenny gave a great overview. I'm not even going to repeat what she said. I'm going to dive straight into the clinical part. So I'll talk about this a little bit later, but one of the things to make sure that you do before your clinical reviewer shows up is to do a little research on them and figure out who they are. From our experience and from talking to others, the clinical reviewers tend to have a bias towards whatever field that they're in. Ours was a dentist and spent a disproportionate amount of time on our dental program to the near exclusion of almost everything else we did, which was strange, but is what we dealt with. So do your homework. But I wanted to dive straight into the quality improvement and the clinical measures section. That's probably the meat of what we're talking about. And this is the quality improvement assurance plan. Having your materials in one place, Jenny pointed this out, is critical. So assembling your QI materials by year and having them for the past few years, including a plan, your meeting minutes, the projects that you're working on, and we'll get into that in a few more minutes, and what's your QI methodology, having that available and clearly spelled out is a really important part that the reviewers are looking for. They're also looking for peer review, evidence of that, how you're doing it, and examples of it. The confidentiality, so having privacy confidentiality policies that are HIPAA compliant. And the last thing, and Jenny touched on this also, is knowing what your UDS changes are. So there are some changes for 2014 for sections 6B and 7, the clinical quality measures. So knowing what they are, and also having a plan for how you're implementing them. Even if you haven't done it yet, having a plan for it is what they're really looking for. So with the clinical performance measures, this is really where your QI plan comes into place. Ideally, you're looking at a couple of clinical performance measures, and you have that as part of your quality improvement initiative. If that's the case, then this is really what they're going to be looking at. So they're going to look at the data, and they have the data for UDS up to 2012 because that's what's posted on the website. You should have the 2013 data for them. I just checked this morning, and it's still 2012 data on the HRSA website. So having that data is real important, particularly if, and I think many of us are in this boat, you're continuously working on clinical improvement. That's not going to be reflected at this point. If you haven't gone through a site visit, then that data is, the 2012 data is a year and a half out of date. So you really want to have that for them and available. and you want to discuss these two measures for your QI plan. For us, we had a couple of measures picked out and ready to demonstrate to them, and our reviewer decided to look at smoking cessation. I can't even begin to tell you why. We do well on it, which is great, but I can't tell you why he did that. So there are quirks to the reviewers that as long as you're prepared, you'll be fine on this. And the other part of the clinical review is a chart review. So you want to have a list of 10 charts ready to review for each service you provide. What we did is we pulled 20 charts, and we went through each one of them until we got 10 charts that we liked the way they looked. Many of our charts have, because we're on an EMR, have strange little characters or strange punctuation in our patients' names or addresses. Those are the things you want to clean up before you give that to your reviewer. You'll want to have a read-only EMR access for your reviewer or charts already pulled. But the most important part is to give them what they want and not to give them before they want it. So they'll decide what it is that they do or don't want to look at. And if they want to look at something, you have it ready. And if they don't want to look at it, then they don't want to look at it. It's usually best to have your either chief medical officer or medical director available at all times throughout the 3-day visit, pretty much clearing their schedule. And this goes true for all of the senior managers who are going to be essentially at the beck and call of your reviewers. They like that kind of access. That was really important. The couple of times that they want to go on a field trip, shall we say, it's really helpful to be able to put into context what's going on because they don't know the context of your clinic. This was an area that they keyed on pretty significantly, which is the required and additional services. So what they're really keyed in on is not just how you're serving your patients within your scope, but also how you're getting them services that you don't directly provide. And this depends on a state-by-state basis in terms of what's available, and even program by program. So contracts with insurers for a lot of your referrals that go through an insurance, whether that's Medicaid, MCO, or some other variation thereof, that's going to be sufficient that you have contracts. Many of us also have agreements for charity care, whether it's through a hospital or a private group, but having an agreement with that provider or organization is key. And having that agreement available for them is what they're really looking for. Referral tracking, there's a large emphasis on how are you tracking referrals, how are you making sure that people get to their visits, and then how are you making sure that the loop is being closed. So are you getting information back, whether it's a fax or EMR document? What are you getting? Are you getting it back, and then are you following up on that referral? And this is actually where we had a finding, which was that we were tracking all of our medical, but our substance abuse services, we weren't tracking them as assiduously. And so that was a finding for us, and it was a good reminder to us that everything here, though we think sometimes of referrals in a very medical context, whenever you're referring out for any service, you need to be tracking it. And then the other thing is whether there are any site-to-site variations. So if you have multiple sites, is this process the same at each site? If you have sites that are far apart, you may have different referral patterns. If so, how are you dealing with that? For the staffing part, a lot of this is around credentialing and privileging. This is where you want to have your HR director available. And one of their comments to us was that, and this is a rough quote, you won't believe how many times we'll go to a health center and see be that the files are incomplete or ragged or not available. They're really looking for complete files with up-to-date information in one location. They want to know that it's all there and it's all up-to-date. So that's an area to definitely spend a lot of time on if you're behind on that, to get those credentialing and privileging files up to par. Accessible hours. They really dug in with us on how we determined what our hours were. We were talking about why we didn't have after hours here, mainly because we have tried that and we didn't have much of a demand, but we did have Saturday hours. They asked us a question about opening even earlier in the morning, and it is something that we've thought about. But they are very interested in how you've determined that and how you're communicating that to your clients. Do you have signs? Is it on your voice message? Are you telling them in person? So they're looking at that. And then the flip side to that is, what are you doing for after-hours coverage when you don't have staff in the building? Do you have an answering service? Do your patients know how to get in touch with you? Are you ensuring that they're calling you instead of directing them to the emergency room, let's say, or to another urgent care facility? Are you making it easy for them to get in touch with you? Or if you have an arrangement for a covering practice, are you making it easy for your patients to get in touch with them? If you do contract with another agency or group, one of the key areas that they're looking at is how you're providing oversight. How do you know that they're doing a good job for you? How do you know that they're taking your patients and not shunting them away, or some other issue where your patients are not having access? This was a critical issue for them, which is hospital admitting privileges and continuum of care. They wanted to know how our patients were being hospitalized. So did we admit them to the hospital? Did we admit them to hospital staff? Did we send them to the emergency room? And whatever mechanism or mechanisms you use, the key is to have written policies around that. So if your staff is doing admitting at a hospital, having admitting privileges and having documentation of that in that person's HR file is critical. If you have an admitting arrangement with a group, having that written agreement, including closing the care loop. So how do you get that patient to the hospital? Who are they being admitted to? How are you getting information to the hospitalist about the patient's conditions, medications, reason for admission? And then how are you getting either progress reports or discharge information back? And lastly, how are you making follow-up appointments for these patients? And then if you're referring to the ER, do you have an agreement with that hospital to send your patients to the ER? With the same idea being that even if you send them to the ER instead of directly admitting them, how are you closing that loop as to what happened in the emergency room if they were discharged, or what happened in the hospital during their stay if they were admitted? And then Jenny mentioned the sliding fee scale, so I'm not going to get into that. And then my few tips are that style matters. The more prepared you are, the more professional everything looks, the better it goes. As with any of your reviewers, you want to have somebody who's essentially their shadow, somebody who's there for the 3 days at their beck and call. And then other key personnel, so having your quality improvement director, your HR director, at least from a clinical perspective, is key, having them available. Written policies and procedures, the more the better. The more you've documented these things, that's a demonstration to them that you've thought about these things and that there's a formal procedure in place. If the vast majority of their time is spent at a table looking through the papers that you're giving them, whether it's the material that you prepared ahead of time or it's ad hoc material they request from you. The amount of time they spent interacting on the clinical floors was probably about 2 to 3% of their time. So really it's focused on what paper can you produce for them. As I mentioned earlier, do your research on who your reviewer is, and you want to know that. And they come out swinging. They come out really hard. And if you can answer their questions and hold your ground for the first day, day and a half, it tends to get a lot better. And with that, I'm going to turn it over to Fran.
Great. Thank you, Nilesh. And both of the preceding speakers have given you a great overview. I don't want to repeat too much, but I will say that just in the context of this shaded box on this slide where I'm going to cover the management and finance area, and particularly these requirements, these topics, really one of the themes that you've heard from both speakers has to do with documents. And unlike with the Joint Commission review where traceability and really following the life cycle of the patient experience is key to that review, unlike that experience, this is all about documentation. Even as Nilesh just said, a small percentage of the time was spent on the clinical floor. The crux of this type of, it's almost an audit, is really spent in reviewing documentation. It's almost that simple. So I really think one of the critical success factors here, and Jenny really mentioned this and hit home on this, is sending as much as possible in advance. And sending it so that they only have a day or so to review it isn't going to buy you much. So the key is assembling your team, really being organized about this, managing it as a project as you would anything as serious as you would undertake an important initiative, and starting enough in advance so that you can ultimately, whether it's 2 weeks or with enough lead time, assemble the documents, some of which you may have to creatively write in the months before, but all of which are things that you would be doing anyway. One of the advantages of doing this review is it focused our attention on housekeeping and even some things more strategic that we would have planned to do at some point anyway. So I highlighted or bolded some of the documents that we sent in advance on the key drives, just to comment on a few of them. Some of them were the gimmies, the low-hanging fruit. Some of them we had them anyway, so they were easy to assemble. But others I wanted to comment on because we got dinged for them. So for example, billing, accounts receivable, and collection policies. We sort of had them in a state that perhaps were somewhat outdated, but nonetheless we had them. Good enough to present, but the fact that they had not gone through a formal board approval process with board approval sign-off and documentation in the minutes was something we got an unmet for. So we didn't get many not mets, but that was one of them. So it's very important that no matter what you do in documentation, looking through those that need to be board approved, make sure you prepare enough in advance, get that on the board agenda or finance committee agenda and then board agenda, and make sure they go through the normal approval process. Sliding fee scale has been mentioned a couple of times, but we found ourselves in the same position as Jenny, which was making sure that you are prepared to substantiate if for those sites that do not have a copay, and we ourselves also do not, and that's perfectly legitimate. You just have to make sure you can defend your position. I believe there's a new PIN that's about to be released anyway, so we did not get written up for that, but just make sure you understand the nuances and can explain that thoroughly. I don't know if I highlighted organizational chart, or perhaps that's on a subsequent slide. We have a fairly robust organizational chart, and our particular reviewer had a high degree of distaste for it. And then at the end, after the long critique, admitted that it was her personal opinion after she had rattled our HR director fairly substantially, and then admitted that it was her personal bias and opinion. So one piece of advice I would say is to, as you go through the review, be prepared to differentiate the critique that's leveled at those things that are required versus those things that are optional or just those things that are sort of their reactions and their opinions. It used to be that they would include their recommendations on non-required items in their report, which they no longer do. Probably got pushed back because it was confusing as to what was required to be in compliance. Two most recent financial audit reports. In our particular case, we got our financial audit released literally on the day that the reviewers arrived, so we ourselves hadn't even previewed it, but we didn't care. We just made it accessible to them. So sometimes just the immediacy and availability of information is more important than its content. And then in addition, of course, to the advanced documents, when they were on site, also as Jenny alluded to, we had binders, we had network documents. Everyone was familiar with exactly what was where, and everyone had access to the identical sets of information. And that's very important just for interchangeability of staff being available to walk the reviewers through those documents. I highlighted on this page subgrantee partnerships and relationships. For those of you who have this situation, we have very solid long-term relationships with subgrantees, so much so that when we looked at our actual contractual relationships, some of them, I won't quite say we've been operating on verbal renewals, but let's just say we have long-term solid relationships, and this provided an opportunity to make sure we contractually had our I's dotted and our T's crossed. So I would say that was something that we probably should have done anyway long ago, and it afforded us the opportunity to visit them, to actually, and of course we were interacting with them all the time and it minimally for UDS reporting purposes, but it really afforded us the opportunity to go visit their sites, take a team out there, bring along people who had never seen those locations, reestablish broader linkages, and so it ended up being a good thing. So I would say for those of you that do have those kinds of relationships, start early enough and make an opportunity out of the contractual updating that's required for this purpose. Same with the MOUs. And as far as the other on-site documents that the reviewers went through, in terms of the financials, we have a standard financial packet. It took us a while to get to the stage that it currently is that we're very happy with. And if anyone needs a sample or a template, we're more than happy to help in providing that. And they spent a fair amount of time with our team asking questions, walking through it. It might be on, I think, yeah, here we go. This financial statement package was something that they really wanted to ask questions about the numbers. They wanted to know, first of all, in addition to the content itself, how those numbers were used, who reviewed them internally, what was done with them, what action was taken, how the monthly reconciliations took place, and then before the board saw them, what management review process took place. So they drilled a lot in this area, in the balance sheet, our income statement, asked a lot of questions about encounter activity by team, by provider, productivity reports. And of course, that's where special discussion took place, and drilled a lot on why productivity numbers were certain ways for certain teams, and that compelled the discussion, as Nilesh said earlier, on, well, how about if you start earlier and do more and do this? And we took the opportunity to engage them in experiencing what life was like here that made it different. And on one hand, while we all know that it is clinically different in many ways, saying that and having them experience, for example, one of our clients practically giving birth on our front porch, and the number of staff and hours that it took over the 3 days of their review to work with that patient and have the reviewers actually witness and experience that, actually changed their point of view from the beginning of the review to the end. And so actually, by the last day of the review, they were not talking about encounters per provider and productivity in the same way they were when they first started. So I'll come to this at the end when we talk about sort of lessons learned and tips, but as Jenny said, even when you can position the room so they can see and experience what it's like to be at the clinic, whatever you can do that allows them to better understand why we're different and why this population demands a different level of care and intensity of care, that will help you help them understand. So that was advantageous for us in the review process. And ultimately, it translated into their ability to understand our numbers, our productivity, and our financials. They asked a lot of questions about cash management, our accounts payable, accounts receivable, specific policies. They were looking for documented receivables policies, billing policies. They wanted to see our rate structure documented and approved, board approved always. And they wanted to look at the audit opinions. They were looking also at our capital budget. They wanted to make sure there was specific review and approval of our capital expenditures, and if there were any unusual activity or expenditure line items, that there was sufficient review and approval. As you would expect, there should be, but they wanted board evidence of board approval of those types of anomalies. So board authority was a big thing, including and right down to making sure that each and every month a board meeting was conducted, even if it was by phone. And whereas in prior, really in probably the majority of years, we would not meet, for example, in August, or we would consolidate the November, December meetings into one, we clearly now no longer do that. And then there were a variety of other miscellaneous topics that seemed to come up. They wanted to see our 5-year strategic plan and our progress in making sure that we had objective, tangible measures and mechanisms for communicating that. And really, those things were the normal things you would do anyway. And the same thing with our bylaws. We were in the midst of having material rewrites to our bylaws, and they were not complete. And we actually were concerned that because they weren't complete, we would have a not met there. But to the extent that they saw we had a very detailed plan, a very detailed level of participation by our board members and by others, and so to the extent that that was very transparent, I think the process was more important than the fact that it was not, that the outcome didn't indicate its completion. So let me jump to the end and give you our top 10 tips. And I would say, I'll go through these quickly because it was very clearly laid out by Jenny how important these aspects are. Start early, create this as formally as a project as you would any other strategic initiative. And when I say identify an administrative quarterback, in addition to the project team, it's really important to have somebody centrally consolidating the library of the documentation that you're going to ultimately compile and have version control and basically keeping it all organized. And then be very candid with yourselves. Identify and prioritize the vulnerabilities. And some things will be low-hanging fruit. They'll be easy to fix. They'll be things you needed to do anyway. And then for those things that aren't fixable in the time frame that you have, and some things are going to be big, like putting in a billing system or things that you know you can't do in that time frame, just put together the project plan and start to execute so that when they come, they'll see progress, they'll know where you are in the plan, and they'll know where you're going. And it's something you would need to do anyway. And then I would say, this goes back to my bylaws example, if you've got a process, it's sound, it's transparent, and even if the outcome isn't at hand or it's imperfect, that's good enough to, at least in our case, for the reviewers to see that you're on track and to see where you are. Scavenger hunts, creative writing, and documenting is sometimes all that you need. Making sure the board meets every month, that was really a big thing for us. Having a good relationship with your project officer can be helpful. We think that maybe over dinner she probably helped smooth the way for some of the controversial things they found. Never underestimate the value of the shiny penny syndrome. If you need to distract them with a story or, hey, we just did our core values, and it takes their mind off of something that was really troubling to them, don't be afraid to use it. Help your reviewers experience how and why we're really different. Don't just tell them about it. Let them immerse themselves in it. And then probably more important than anything else, realize that there's probably nobody in the room that's working in a health center that's doing so badly that you're going to be jeopardizing your funding. I mean, it's just impossible to fathom that anyone could be in that position. So the main thing is keep your sense of humor, keep your eye on the ball, stay focused, stay organized. You'll get through it and laugh when it's all done. Julie, I think I'm passing the ball to you.
Great. Thank you, Fran, and thank you to all of our speakers for a great presentation. We have a few more minutes for questions and answers, so if you would like to ask a question to one of the speakers, please type it into the Q&A pod below the slide. I would also suggest adding your email address just in case we run out of time and we can't get to your question live. We can follow up via email. So I'll go ahead and ask. The first question goes to Jenny. Erica would like you to go over how to ask for a reviewer with Healthcare for the Homeless experience, and maybe talk a little bit about what that experience was like to get a reviewer with that type of experience.
Sure, and I think I can do it pretty quickly. I almost put a drum. We have a picture of drummers, our drum beat slide for PowerPoint. Sometimes I almost put it in there, and this is one of those just keep the beat going. You work through your project officer who will have involvement in selecting those reviewers, and we asked very early on as soon as we knew, and we just kept asking and asking. I don't know that it really kind of depends on the project officer. It depends on which reviewers are available. There are people with very direct healthcare for the homeless experience. I mean, we've all tried to make sure that we have some of our peers there. So that's been very intentional. They're there. Sometimes it works, sometimes it doesn't, but we just kept asking. And what I learned in asking, that first I asked for someone with HCH experience, and I wasn't explicit about what I meant by that. So what we were assigned through our project officer were people who had reviewed HCH grantees before. And I had a conversation with her. You know, I pushed to request that maybe she change out at least one person, and she essentially told me when that conversation wasn't going to continue and when it wasn't going to happen. And then at that point, I thought, all right, I tried. So we did end up having a good experience with people who had reviewed HCH grantees, but I think to Nalesh's point, we really set the tone with them. We really took every opportunity to show them who we were, what we were about, and that we had a good grasp of the policy that established that for special project grantees. So I'd say just start asking and keep asking.
Great, thank you. This question comes from Nicole. Are there any recommendations for what to provide when we have not had a UDS cycle yet and have no UDS type of information for the reviewers? We are a new grantee, and I will see if Nilesh can respond to that question.
Sure, thank you for the question. So what I would recommend is that you have a documented plan for how you're going to generate your UDS data. Since you haven't had to report it yet, you haven't reported it yet. They want to see that you're going to be able to do something. If you are able to produce some interim UDS data, you can do that and keep it to the side. If they ask, you give it to them. But otherwise, the plan for how you're going to do that is the key. Back to you.
Great, thank you. This question comes from Nikki, and I will let Jenny respond to it. She asked, is it acceptable for the board to designate key leadership staff to review and approve policies?
I would suggest no, with the caveat that what we did that seemed to work pretty well, we definitely had the board approve more policies than fewer. So we opted to just get them out there and get it signed. We had the time to do it. It was on the agenda. We did much of the work. Our committees are very active, so we did overkill and over-prep on that one. So if in doubt, get it signed and approved. I would say that on policies and procedures and protocols, which were also voluminous, we had our senior management team, as per our policy and process, we had the senior management team review and approve those at our meetings. So that's how we split it out and distinguished.
All right. We did receive a few questions related to sub-grantees, and I do want to clarify for the audience, there is a difference between sub-grantees, or they're also referred to as sub-recipients, and subcontractors. So we did receive a few questions about sub-grantees, and neither of our presenters have sub-grantees as part of the program. So I will rephrase this question and see if Nilesh can respond to this. For your subcontractors, did the reviewers visit the sites? And if so, what was the review like? And there's additional part, should they have a binder? So should the subcontractor have a binder with their own 19 points ready and collect documentation on how they're meeting the 19 program requirements?
Let me take my stab at this. So we have subcontractors. At the time of our review, we actually weren't clear on the status of our of the programs we were funding, whether they were sub-grantees or contractors, subcontractors. They did not visit them. We did prepare. We actually visited all 5 of our subcontractors, and we did some prep, and we were prepared to take them out there. They were not interested, not even slightly. And when we've heard, and we have a convalescent care program which they did go to, but that was more of a interesting, fun thing to do than a looking in detail at it. In talking to others, the reviewers seem really keyed in on sitting where they are and looking through paperwork. As to going through the 19 points for each of your sites, I think you're much better off delineating, having a contract or MOU that delineates the responsibilities of those parties, and you definitely have to have that. But I do not think you, particularly for the contractors, I won't speak for the sub-grantees, but for the contractors, you definitely don't have to do the 19-point review or anything even close to that.
That's right, and this is Fran. I will add that it took them a while to make the distinction on whether these arrangements, these partnerships, were sub-grantee or subcontract relationships. And the main thing that we had to ensure for ourselves, at least, was that the contracts were up to date. If they were not automatically renewed through some clause, that those kind of evergreen clauses were written into other, future arrangements, that the terms and the outcomes were clearly stated, so that the contractual arrangements at least were signed, were clear, and so forth. So at least the terms should, all of that should be up to date and clearly legally binding in your documentation.
Great, and we'll respond to one more question. Again, if we did not get to your question, we will follow up via email. So continue to submit those to us, and we will respond to you. The last question for Fran states, I don't see it, but the request did not include aged accounts receivable payables. How outstanding how outstanding were their accounts?
We did provide an aged accounts receivable report as one of the financial reports they reviewed. And so if anyone, wants any advice or help about any of the types of reports they requested on top of the normal package we give, we'd be happy to tell them about it.
Great.
So we went out to 120, 150 days, from current to 150.
Great, thank you. And again, thank you to all of our presenters. So that will conclude the Q&A session. Here is a slide of a few resources, some that were mentioned throughout the presentation. And thank you for joining the Preparing for HRSA Operational Site Visits webinar produced by the National Healthcare for the Homeless Council. And again, thank you to our presenters and thank you to our attendees for joining. I will now close this meeting.